Hello everyone, we are Group 1 and we will be presenting about iron deficiency anemia. Our case study is about Todd, a 52-year-old male with a past medical history of GERD and hypertension, who was recently diagnosed with iron deficiency anemia. After discussion with his physician, he agrees to try adjusting his diet to include more iron. After several months, there is no improvement in Todd's condition. His primary care physician prescribes an initial dose of ferrous sulfate 325 milligrams by mouth twice daily. However, after 2 weeks of taking ferrous sulfate, Todd returns to the clinic with complaints of upset stomach and no longer wanting to stay on this medication.
Some things to consider prior to iron drug therapy would be to know that it's important that over time, GERD can erode the esophagus and cause bleeding. Iron deficiency can develop due to this blood loss. The proton pump inhibitors and H2 agonists used to treat GERD can interfere with the body's ability to absorb iron and lead to iron deficiency. It is important to prescribe the correct dose for individual needs to avoid iron toxicity. It is also important to know that decreasing hemoglobin levels can elevate blood pressure. Research shows that anemia causes high blood pressure, so consider correcting anemia and reevaluating antihypertensive after anemia is corrected. Iron may interfere with the body's ability to absorb certain medication. It may also decrease absorption of ACE inhibitors, and bile acid sequestrants may reduce absorption of iron. Iron has a low absorption rate and may require 3 times daily dosing in order to reverse iron deficiency. Consider prescribing vitamin C to improve absorption rate by as much as 48%. And also remember that common side effects of iron can contribute to heartburn and aggravate GERD, including constipation, acid reflux, nausea, vomiting, and upset stomach.
An upset stomach is a common reason why patients are non-compliant with their iron regimen. Ways that we can improve adherence include decreasing how often they take the iron from daily to, say, every other day. We could also encourage Todd to take his iron with food or milk to prevent GI upset. Even though it will delay absorption, it will improve his adherence. We could also change to a different iron formula supplement, such as ferrous gluconate, with a lower amount of elemental iron. Or we could switch him to an iron elixir where he can take a smaller dose and titrate the dose up as he tolerates it. Lastly, if he cannot tolerate the oral iron, he could be switched to IV iron instead.
So symptoms to monitor. Some adverse effects include darkening of stools, abdominal pain, heartburn, nausea, constipation, flatulence, vomiting, and diarrhea. Toxicity has 4 phases. The first phase is acute GI irritation, epigastric pain, nausea, vomiting, diarrhea with green and tarry stools, melena, and hematemesis associated with drowsiness, pallor, cyanosis, lassitude, seizures, shock, and coma, and may even result in death. The second phase is a transient recovery period. The third phase is CNS abnormalities, metabolic acidosis, hepatic dysfunction or necrosis, renal failure, and bleeding diathesis. This may further progress to cardiovascular collapse, coma, and death. Late toxicity effects associated with iron include intestinal obstruction, pyloric stenosis, hepatic cirrhosis, or severe gastric scarring.
So while Todd is on ferrous sulfate, it will be important to perform a few lab tests such as hemoglobin, hematocrit, and reticulocyte count. These should be monitored every 3 weeks during the first 2 months of therapy and periodically thereafter. Serum ferritin and iron level can also be monitored to assess the effectiveness of the therapy. Rise in hemoglobin and hematocrit may take up to 2 weeks, but the reticulocyte count will provide information immediately as new red blood cells are being produced. Hemoglobin will increase within normal parameters in 1 to 2 months of therapy. It may even take up to 3 to 6 months for normalization of iron stores in the body. Also, the GUI test can be performed to determine if TOD is losing blood through the GI system.
So the patient education that we should provide for Todd to help improve his adherence with his iron regimen include the reason and the importance of taking his iron preparation, not only to treat his anemia and restore the iron stores in his body, but also they have an impact on his other comorbidities as well. And it would be important to explain these things to Todd. Patients tend to not adhere to their medications if they don't fully understand the rationale for why they are taking them. But if you talk to the patient and stress the importance of taking the drug, patients' adherence is more likely to increase. We could also be willing to alter the therapy for Todd and show him our willingness of that we have more options for changing his therapy if he continues to have intolerable GI effects on his medication. We also need to educate him on the long-term benefits of taking the medication, such as having improved energy and mood. Currently with anemia, he probably feels very weak or tired most of the time, short of breath. He's probably intolerant to cold, and he also has increased susceptibilities to infection, and he may have a depressed mood. So by taking his medication, the long-term benefits of that would be an improved energy and mood.
Some key points and consideration or conclusions for the presentation are that the patient has iron deficiency anemia. Pharmacological regimen was causing intolerable GI symptoms, and the patient therapy changed to increase adherence. Some questions for the audience are, how does having anemia affect Todd's hypertension? If continued GI upset continues with every other day oral therapy, what would be our next step? How long should Todd's iron therapy continue after hemoglobin and hematocrit levels are within range? And here are our references below that.